Thank you. So I'm presenting this on behalf of Dr. Vijay Patil, who was unable to be here today. So the last topic, this is on more targets, more drugs, and more choices, what we as medical oncologists want for our patients. So just like we saw in the talk, two talks prior to this, was the different techniques of biopsies and how important it is to get a biopsy. And the main reason is because we as medical oncologists keep demanding for multiple biopsies from the radiologists. And it is because of this that we have more options and to improve the outcomes of our patients. So if you look at the way treatment has evolved in non-small cell lung cancer from over the past probably 2 decades, you can see that 20 years ago, we reached a kind of a ceiling where we would not be able to improve outcomes beyond a particular point with use of different drugs. So the hype 20 to 25 years ago was on the newer drugs that came, the taxanes and other new drugs that came over the older drugs such as the alkylators or platinums. And everybody thought that the use of different chemotherapy combinations would probably improve outcomes. But this study, which was published in NEJM 20 years ago, showed that whatever platinum doublet outcome that was used, there were 4 arms there. They used paclitaxel with cisplatin, gemcitabine with cisplatin, docetaxel with cisplatin, and paclitaxel with carboplatin. These are commonly used even today. And they saw that whatever we did, around a median survival, it was around 8 months. And this holds good till this day. We don't really cross a median of 1 year in most patients treated with chemotherapy alone. And what they saw is with all these regimens, if you look at the 1 year survival, at the most 35 to 40 patients survived, and it didn't go beyond that. The combination partner didn't matter. That is, you had to use a platinum. The other 3 drugs, they gave similar outcomes. So this is when we realized that we keep trying to switch chemotherapy regimens and do a lot of things with the chemotherapy combinations, but a doublet platinum-based chemotherapy, whichever partner you use for the platinum, it didn't really change the outcomes much. And we kind of it came to a plateau in the management of non-small cell lung cancer. So this is where molecular profiling changed the treatment paradigm in lung cancer. So this is why we want more, we need more biopsies and tissue to profile the tumor. And as time has gone by over all these years, there are multiple new targets that have been identified. So the initial target that was one of the early targets that was identified was EGFR. And EGFR now, we all know that is one of the most common targets. It has a racial or a population-based variation. In our country, it is intermediate between the extreme east and the western population, but we still have a significant number of people with EGFR mutations. So it's important to identify these patients. The importance of these molecular markers is not just for treatment. It is that these markers are drivers. They are driver mutations in the cancer. So they predominantly drive tumor growth, and blocking this pathway leads to a very dramatic response and control of the disease. So the most common markers which have targeted drugs today, and which we'll just briefly go over in this short talk, will be the EGFR, ALK, ROS1, MET, RET, BRAF, NTRK, and HER2. If you look at the most common, it will be EGFR and ALK, probably followed by MET and ROS1. RET, BRAF, and NTRK, HER2 are very, very rare. They are around 1 to 2% of the non-small cell lung cancers. So like I just mentioned, we have around, this is a data from our center itself published in 2013. The incidence of EGFR mutations in India, roughly from various papers, ranges from 23 to 29%. This is our data. There are other papers which have reported up to 29%. And like it is known, EGFR is seen more in, if you look at the these graphs, they show that they are seen more in females and non-smokers. And this fits with the profile that is known. In the Caucasian or the Western population, it's much lower. It's 10 to 15%. And if you look at East Asians like Chinese, Koreans, and Japanese, it can go up to 50%. So this is the same table which was depicted in the figure, which shows a higher number of females, never smokers, and adenocarcinomas, and females with adenocarcinoma who had higher levels of EGFR mutations in them. So what is EGFR? Basically, EGFR is the epidermal growth factor receptor, which is seen on multiple epithelial cells. It's not exclusive to lung. There are certain parts of the gene which have mutations which are seen in lung cancer, and they can be targeted. Just to remember that a large, the 4 main EGFR exons that are looked at are 18, 19, 20, and 21. The most common, that is more than 90% of the EGFR mutations happen in exon 19, that is a deletion of a section of exon 19, or a point mutation in exon 21, that is L858R. So if you look at most of the lung cancer patients, they will have these 2 mutations, that is around 45% of each. Only around 10 to 15% of patients will have other mutations in the EGFR exon, which will be in exon 18, 20, and some of them in 21. These rare mutations have some sensitivity to EGFR TKIs, except the exon 20 mutations, that is a T790M, but now we have osimertinib, which targets that as well, and the exon 20 insertions. Right now, there is no effective drug for exon 20 insertions in the first line. There are monoclonal antibodies in trial for them. So just to remember that 90% of patients will have deletion 19 and L858R in 21, and the rarer mutations, which some of them are sensitive to current therapy. So this is most of the studies which were done with EGFR mutation patients were with geftinib with pemetrexed platinum. So that was the standard comparison at that time. So this is our study which had compared these two. And similarly, these are the various studies across the world which compared geftinib. So IPASS was the first study. Just a little bit of history about IPASS. IPASS was not designed as a study to compare geftinib in EGFR patients. It was just geftinib in all non-small cell adenocarcinoma patients versus pemetrexed chemotherapy plus carboplatin or cisplatin. And in that, they had as a planned subgroup analysis the molecular testing for EGFR mutations. And that showed a dramatic benefit. So this trial overall did not show any benefit in the whole population of using geftinib, but in the subgroup analysis, the EGFR positive patients had a significant improvement in progression-free survival. The overall survival didn't change much with geftinib. And that led to the series of other studies with geftinib and erlotinib. So you can look at this, the boxes which show the median progression-free survival with all these studies of geftinib and erlotinib significantly improved the progression-free survival, roughly double of chemotherapy. The overall survival in the earlier generation, so we have 3 generations of early EGFR TKIs, which are geftinib, erlotinib, which are the first generation, afatinib and dacometinib, which are the second generation, and now the third generation, that is osimertinib. So the older TKIs didn't really change the overall survival of the patients. Invariably, it was similar, but the new drugs such as dacometinib and osimertinib also improve the survival in EGFR mutated patients. So we know that there's a significant benefit in treating these patients with targeted therapy. And around 1/4 of our patients are going to be EGFR positive, and it is important to test for these mutations. So we commonly test EGFR in adenocarcinomas, but EGFR mutations in lung cancer has also been noted in squamous cell carcinomas. So the typical EGFR phenotype, what we say is female non-smoker patients, may not always hold true. We have noted them in smokers as well and in squamous cell carcinoma, but the incidence is much lower. Goes up to 5%, but it has been demonstrated. And this is one of the papers from ACTREC where they had looked at a molecular profile of the squamous cell carcinoma patients. And you can see these are the various genes that they have noted in the squamous cell carcinoma, right from TP53 to other genes, including EGFR. So another gene that is seen in lung cancer, and it is also seen in other carcinomas, is the KRAS gene. This gene is in the downstream pathway, basically the RAS-RAF pathway, which is downstream of EGFR. It's a gene with poor prognostic indication. For a long time, the KRAS gene didn't have any target in lung cancer. It just said that if you had EGFR mutation and a KRAS mutation, you did worse with TKIs. And a lot of people recommended that those who had KRAS mutation should be treated with chemotherapy, and even then they had a poorer prognosis. This is recent data. This is a drug which was tested in a phase 1 study and received early accelerated approval, that is sotorasib, for a particular point mutation in the KRAS gene. And then after this, there's another drug, which adagrasib, which has also been studied. And larger trials with these drugs are ongoing, and new drugs are being researched. So just a small word which I had mentioned earlier about the rare EGFR mutations. So these are all the rare mutations: exon 18, exon 20 insertions, exon 28, L86Q, 861Q. So multiple are there, and you can get them in combination as well. Many of them have sensitivity. So you can see that they have some response to TKIs. It might be variable with each of the rare mutations. The common drug which has a lot of clinical trial data for rare mutation is afatinib, because in the Lux Lung trials, when they studied this drug, they allowed rare mutations to be included, which the earlier first generation trials excluded. So a lot of data is there with afatinib for the rare mutations. Some people consider it to be the preferred drug, but osimertinib works as well, though we don't have very robust phase 3 data. So this is the current standard of care, which actually has transformed the treatment with the benefit both in the second line setting, which was so dramatic, and then in the first line setting is osimertinib. It's a third generation TKI. And in this study, it was tested and it showed a significant improvement in progression-free survival as well as overall survival. You can see the blue line is osimertinib in all the curves. So in different settings, they have seen in the full set, in patients with brain mets, in patients without brain mets, and the overall survival. This was the initial publication, and on a follow-up publication, they showed that there was a definite around 6.5-month overall survival benefit. The advantage of osimertinib, of course, is the CNS activity as compared to the old drugs. They have very poor CNS penetration, and most of our patients usually ended up progressing in the brain with probably the extracranial disease being controlled. And also osimertinib came for the secondary mutation. So a lot of these cancers, these receptors lose certain portion of the receptor, or they change the conformation to get mutated and cause resistance to the older drug. So osimertinib was acting against the T790M mutation, and it is effective. It was developed in the AURA study for the T790M, and then they tested it in the first line setting. So it is effective in all subgroups, whether you had brain mets or without brain mets, in different performance status, and whether you had EGFR exon 19 or L858R, it didn't matter. It benefited all these patients. But there is a problem with osimertinib in our setting is the affordability, and that is the main limitation. We offer all our patients, but the original osimertinib is hardly, probably maybe only 10 to 15% can actually afford to take it. So that brings us to how can we improve outcomes without osimertinib, and this has been studied not just in India but in other Asian countries like Japan, who also had a similar study called NEJ009, which was also published around the same time, where they looked at adding chemotherapy to the first generation TKI. So geftinib with chemotherapy. It was studied in two settings. One is in our hospital, Tata Memorial Center, and the other one was in Japan in a multicentric trial. And it showed that using the strategy of targeting both the pathways, again, there was a significant survival benefit, and there was a doubling of the median progression-free survival from 8 to 16 months, and the overall survival also improved, and it was not reached in the combination arm. So geftinib with chemotherapy is an alternative. If patients cannot get osimertinib, we often use it. But again, with multiple agents, the number of cumulative toxicities also are going to be increasing. So this is a short table which just shows an overview of the various strategies of combining a TKI plus something else, that it might be chemo, or it might be an anti-VEGF agent like erlotinib with bevacizumab or ramucirumab. So there's a little lack of long-term survival benefit with the anti-VEGF agents yet, but there is an improvement in progression-free survival. So they could be considered as one of the options. And both the Japanese study and our study showed that there is a definite progression-free survival improvement. In the Japanese study, it was 10 months, 9 months, and in our study, it was 8 months, and a definite overall survival also. The Japanese study, the median overall survival was 50 months, which is around 4 years for an EGFR positive patient, which is a very good overall survival. It is comparable or probably even higher than what was reported for osimertinib in the FLORA study, which was 38.9 months. So our first line options, geftinib, erlotinib, unless patient is very frail or really cannot afford anything else, we use it. Afatinib is another option. Generics are available and it is affordable and not at all expensive. The other drugs are dacometinib and osimertinib. You can look at the cost and the other combination options and how we can probably offer this to patients who can't afford osimertinib. So TKI with chemotherapy or anti-VEGF agents. The next important mutation that we need to keep in mind is ALK. In Western literature, it is reported as up to 5%. In our setting, we have reported it up to 7% of patients. It is a mutation which has a dramatic benefit from targeting ALK in this group. So You can see this is some data from our hospital. And if you look at the ALK positive patients who received crizotinib, which is the green line on the figure there, versus those who didn't receive crizotinib, and you can see the survival and how much it has impacted the survival. You do far worse, but patients who received crizotinib did much better. So this was the first study. It was a phase 1, then expansion with an expansion cohort, which showed the benefit of crizotinib. And then multiple ALK inhibitors have come after that. And just to show you, this is a summary slide of all the drugs that are available. Again, crizotinib is a first generation, and then we have ceritinib and alectinib, which is a second generation, and lorlatinib, which is now a third generation drug in the ALK inhibitors. And just like EGFR, the better the generation or the higher the generation, the more the CNS activity, which is a big improvement, because a lot of the survival depends on the presence of brain mets. And you can look at the median progression-free survival and the follow-up also. You can see with profile, that is crizotinib, the PFS is around 10 months. And with alectinib, it is around 35 months. So there's a significant difference. And in the alectinib, your progression-free survival is 3 years. And in the updated survival, the overall survival is, a median is around 6 years. But like osimertinib, alectinib is around 6 lakhs per month. So out of reach of most of our patients. Another mutation commonly tested and seen is ROS1. So ROS1 again has a similar, it's a rearrangement like ALK, and it is also, ROS1 can be treated with ALK inhibitors like crizotinib and ceritinib. The newer generation of ALK inhibitors don't work as well for ROS. And there are some new drugs which like entrectinib, which are anti-RK inhibitors, but they have a ROS1 activity and they are in study. So ROS1 is another mutation we commonly test in our clinic. And definitely ROS1 patients, this is data from the profile study where patients with ROS1 were treated with crizotinib, and there was a 1-year overall survival of 79% of these patients, which is very good in a metastatic or a locally advanced lung cancer not suitable for any other local therapy. So BRAF is another mutation we commonly see. The V600E is the mutation that is targeted. These were early studies which targeted the V600E only with the BRAF mutations, I mean BRAF agents, that is vemurafenib and dabrafenib. But we know that they develop a downstream pathway, MEK activation, and they develop resistance. So current practice for most of the diseases where BRAF V600E is detected is to give a BRAF inhibitor like dabrafenib with the MEK inhibitor, that is trametinib. So similarly, this is the early phase studies for dabrafenib and trametinib in lung cancer. And there has been phase 2 studies which have shown significant improvement. And now dabrafenib, trametinib is one of the approved options for use in lung cancer with V600E mutations. So the MET is the next gene. I'll just briefly go over. The MET gene has 2 types of mutations that you can see. One is an exon 14 skip mutation, that is during a DNA translation and then subsequently transcription and then translation. The exon 14 is skipped, and this disrupts the MET signaling. And basically, this MET exon 14 has some protein, some part of the protein which helps the MET get degenerated or ubiquitinated and cleared off. Because of the skipping of exon 14, the MET receptors in the cell are not degraded, not cleared off, and they keep remaining on the cell, and the number of receptors on the cell are more. So MET has a ligand, which is the HGF, which binds to the MET, and then there's a downstream pathway signaling, basically signals cell proliferation. So the cell keeps on proliferating and it drives the tumor. A lot of time MET mutations or like skip mutations or MET amplifications are seen in the second line setting where you develop resistance, and MET is one of the known resistance pathways for patients who have progressed on EGFR TKIs. So 2 main drugs are available, tepotinib and capmatinib. Again, tepotinib will be available in the near future, not yet marketed in India. Capmatinib also not easily available. But in case we don't have access to these drugs, crizotinib has a good MET activity and it can be used. So a significant responses are seen with the use of crizotinib as well. So most of our MET patients who don't get these newer drugs are treated with crizotinib, at least in the first line setting. So tepotinib was studied in this study where they included MET exon 14. Tepotinib study, this VISION study, did not include patients with the MET gene amplification. So this was the treatment naive group, which had a 90% of the patients had tumor shrinkage. which is not seen, such kind of deep responses are usually not seen with chemotherapy. And even in the second line and beyond setting, there were a significant number of patients who had partial response and stable disease. So this is the responses are durable in the sense that they last longer. So you have the patients in the treatment naive setting having a duration of response around 32 months, which is nearly 3 years, and a median overall survival of 29 months, which is 2.5 years. So it is a significant improvement. And even in patients who have failed one line of treatment and received MET in the second line, they have a median overall survival of 22 months, which is a good overall survival in the second line setting. Capmatinib is the other drug. This was a phase 1 study again, and you can see the response rates. So this basically assessed patients with both the MET exon 14 skip mutations and with the gene copy number amplification. So gene copy number more than 10, and they found that patients more than 10 had good responses. TRK, I will go in very brief. It's a very rare mutation. Less than 1% of the patients with lung cancer get it. So most of the studies with TRK, since they are rare mutation, they are basket studies. It's tumor agnostic. Multiple tumors are included in one study, and it's a driver mutation based. So it's a fusion which is very commonly seen in pediatric tumors like infantile fibrosarcoma, gliomas, sarcomas, thyroid cancer, and rarely you can see it in some adult tumors such as glioblastoma, a particular type that is a secretory carcinoma in the salivary gland, secretory breast cancer, and lung cancer and thyroid cancer. It is pretty rare. The NTRK fusions, that is fusion with another gene partner, are the ones which predict response to therapy. And larotrectinib, these are the drugs which act on it. And you can see the different colors indicate the various tumors, and they have shown the duration of response and the progression-free survival of 1 year. So 55% at 1 year remain progression-free. And this is a mixed bag of tumors because this was a basket study for larotrectinib. So this is the other TRK inhibitor, which is entrectinib. And there are newer generation of TRK inhibitors still in study. So this slide just shows the resistance mechanism, that is mutations in the gene, and then the second generation TRK inhibitors can be used, or alternative mutations that can happen off target like KRAS, MET, and BRAF, which make them resistant to the TRK fusion drugs. So this is a rare mutation, but in those who have this mutation, they get very dramatic responses to the drug. Unfortunately, both the drugs are not available in India, but if there are some trials available across the world, if patients can access them. The next mutation is the HER2 mutation. We know that HER2 is one of the important mutations in breast cancer and has a significant impact with HER2 inhibitors. So HER2 was studied in lung cancer. There is some case reports of HER2 even being seen in a familial pattern of inheritance in lung cancer. So various anti-HER2 therapies have been studied. So this is one which was presented in ASCO way back in 2018, where they studied a trastuzumab drug antibody conjugate, that is trastuzumab combined with a cytotoxic agent, that is emtansine, so TDM1, which we commonly use in breast. And these are various studies that have studied HER2 mutations. So just to note, trastuzumab by itself doesn't really have any significant improvement in survival. Second thing is that pertuzumab also didn't have any great responses. You can look at if you look at the fourth row from the bottom, the response rates were 0% for pertuzumab, and TDM1 showed some objective response rates of around 44%. So trastuzumab as single agent, trastuzumab with chemotherapy is not preferred in lung cancer, unlike breast cancer. So there's a difference in the HER2 in lung cancer and breast cancer. Also, HER2 IHC expressions do not predict anything. So if you have IHC for a HER2 in lung cancer, you really cannot use it to predict the response to any HER2 agent. It is not used. So in HER2, like EGFR, you have to look for gene mutations in the DNA. And there are particular exons, again, exon 19 and 20, which have multiple mutations, similar to the exon 19 deletion or in-frame deletion or indels, what we call in the EGFR genes. They're similar kind of mutations that happen in the exon 19 and 20. And they predict for responses to this drug. This is a new antibody drug conjugate, again, has benefit in breast. That is, if you look, there's a Destiny trial in breast and in GE junction cancers. And this trastuzumab deruxtecan has shown benefit in patients even who have progressed on trastuzumab. So this in a phase 1 study in lung cancer has shown objective response rate of 55%, and overall survival. And now remember, this study was conducted in patients who had progressed on standard therapy, so second or third line, and in that the overall response rate of 18 months. So there is a phase 3 study which is ongoing to see if this drug will compare to chemotherapy plus pembrolizumab in the first line setting. It has just started, so it will take time for us to get the result, but we have a target for HER2 as well. RET is another rare mutation. We know RET is one of the common mutations seen like in specific type of thyroid cancers, so medullary thyroid cancer. RET is seen in multiple other cancers as well. So just like NTRK, these studies are basket studies where they had a phase 1, phase 2 trial, which allowed all tumors, that is all solid tumors with the RET fusion, to receive this drug. And then it had a phase 2 expansion cohort, which 160 milligrams was given twice a day. And again, the responses that were seen, so objective response rates in the patients who were newly diagnosed was 85%, and patients who failed chemotherapy was 64%. And this is in lung cancer. They also included patients with thyroid cancer and other cancers. So based on these early phase trials, this drug selpercatinib and the next drug pralsetinib have received approval, but again, phase 3 trials are going on. So this is another similar study where they use pralsetinib in patients with RET fusions. And this is seen in multiple tumor sites were allowed to be included. And this also showed a response rate of 61% in patients who had failed prior chemotherapy, and in newly diagnosed patients, 70%, with a progression-free survival ranging from 9 to 17 months. These drugs are being tested in a larger phase 3 trials, not available in India at present. So currently, if we have a RET mutation, we can use older drugs like cabozantinib or vandatinib, which are used for thyroid cancer. They have a RET activity. So even if we don't get these drugs, we can use them. But currently in lung cancer, in absence of access to these drugs, chemotherapy would be the first line treatment, and the other RET mutant drugs like cabo or vandatinib, we can use in second line. I will not go into the checkpoint inhibitors because we are running out of time. So just let's conclude that we know the treatment of lung cancer has changed significantly, and targeted therapy and immunotherapy has significantly improved outcomes of this disease, which previously had a very dismal prognosis. So we know the importance of diagnostic tests and biopsies and for us, because it changes our treatment. And it is one of the preventable causes, because tobacco is one of the major causes for lung cancer in our country. With this, I'll end. Thank you.